Hey guys, this is Charles Clinton on Chapter 19, 9th edition, Cardiac Catheterization. This in orange is what we're gonna start to talk about in this video. Next videos for next sections. Origins in 1711, biventricular catheterization on a horse. 1929, this guy Forsman uses a ureteral catheter, takes it up to his right atrium, goes down to the radiology department to get his x-ray taken. In the 1940s, Cornand and Dickinson Richards redesigned Forsman's catheter, and today in the USA 80% of hospitals offer the service. I liked this last line, which says, performing the right procedure on the right patient for the right reason in the right way for the right outcome. And here are indications for diagnostic cardiac catheterization. Main indication, coronary artery disease, acute coronary syndrome, of course. Another one is when you have a symptomatic patient plus high pretest probability, or if you have a symptomatic patient with discordant or intermediate risk on a stress test. Okay, what about stress test? Yeah, high risk or discordant or intermediate risk plus symptoms. Other reasons to do this: new left ventricular dysfunction or regional wall motion abnormality, of course, of an unknown etiology. If you have a clear etiology, you probably aren't searching for the coronary artery disease. Lesion of unclear severity or more equal to 50% in CT angio. Also resuscitated acute coronary sudden cardiac arrest patients, or VTAC when you suspect an ischemic cause. Valvular heart disease in those patients that are preoperative, or if there is discordance between, if you have pulmonary hypertension or left ventricular dysfunction, which is discordant with valvular heart disease severity, or a patient with symptoms that are much more than what you see on the echo findings or any other valvular heart disease severity established. Pericardial disease, if you suspect tamponade, or you suspect or are uncertain if the patient has constrictive or restrictive physiology. In the cardiomyopathies, by the reasons shown there. In pulmonary hypertension, if there's equivocal or increased right ventricular systolic pressure, if there is an unclear cause for the pulmonary hypertension or unclear intravascular volume status, response to medications. Before initiating these medications, of course, you want to know they're working in this context, reducing the pulmonary hypertension, and of course, you want to know that the patient has effects that are maintained and over time. Also in heart transplantation and in intracardiac shunts, also to determine the anatomy and physiology. In which scenarios not to do the cardiac catheterization? I'll tell you some key words. In asymptomatic patients with low to intermediate risk and low pretest probability, you have to ask yourself twice if you want to take them to the cath lab. Remember the number 5. Low risk is a Duke score more than 5, Duke treadmill score more than 5. Or if you have a non-invasive test which shows low risk findings, like less than 5% ischemic myocardium. And also, if you find non-obstructive disease, this means less than 50% stenosis anywhere. For the other characteristics, you can read them in this slide or pause the video. In this other slide, you can see patients with known obstructive coronary artery disease. What are the keywords here? Patients that are asymptomatic, that are stable, without changes of their symptoms, with concordant symptoms with the pathology you are suspecting. Low risk patients and without severe valvulopathies. Those patients, think twice about taking them to the cath lab. What about the operational aspects of the cath lab? First guidelines in 1991, then 2001, and now updated in 2012 and 16. There are 4 different types of cath labs. One is the hospital-based with or without cardiovascular surgery support. Right now, those hospital-based without cardiovascular surgery support are the least of them, 1/3 to 1/4 of them. Then you have the freestanding labs and mobile labs. These are for select low-risk patients. You want support if you have high-risk patients. What are high-risk patients? Pulmonary edema caused by ischemia, NIHA class 4 secondary to valve dysfunction with reduced ejection fraction, complex congenital heart disease, and acute coronary syndrome unless PCI is possible, and high risk of vascular complications. What are the hybrid labs? They are high-resolution cath labs plus the capabilities of the OR. Now, what about equipment? You have the high-resolution X-ray imaging system that will give you a fluoroscopic and cine mode imaging. How do you reduce exposure? This is determined by the radiation exposure is determined by frame rate and energy output. Remember, cath lab frame rate is pretty high. The reduction of exposure can be done by fluoro storage, image processing, and road mapping. This means that there's less exposure, and the hemodynamist or the specialist will see the images without exposing the patient to more radiation. Individual contrast administration is given usually in 10 ml syringes typically, but if you need to fill in the whole ventricle, you'll use more than this. Radiation safety, ALARA, as low as reasonably achievable. Then the cath lab in general, each patient will be radiated or exposed to 1 to 2 millisieverts. In average 3 to 5. This is the equivalent to 2 to 3 years of natural background radiation. Determinants, deterministic effects. It is dose dependent. This is talking about cataracts, hair loss, and the most common deterministic effect is skin injury. Goes from erythema to necrosis. There's a term called interventional reference point, which means that at least the X-ray tube has to be not closer than 15 centimeters. This is to reduce exposure. Then you have these stochastic effects, which are related to probability and not that much to dose. But of course, at more exposure, more probability of these stochastic effects, which are manifested as neoplasms or genetic defects. What about radiation safety? You have to minimize radiation exposure by decreasing fluoroscopic beam time, least magnification possible, use beam collimators, and the optimal X-ray positioning, avoiding extreme angles. For example, the LAO is the highest risk projection. What about estimated patient dose? You are usually estimating this continuously. You are following this in time. You have a term called the air kerma, which is the absorbed dose to air times the cross-sectional area of the X-ray beam. If you get a value 6,000 milligrays or more, you should report this and think about it. 2 film badges, one outside and the other inside the apron. The one inside is used to see if the lead apron is working. What is the maximum allowable whole body radiation dose per year? It's 5 rem, Röntgen equivalents men. 1 rem is equal to 50 millisieverts, or 50 rem in a lifetime. This would be 2,500 millisieverts in a lifetime. How to reduce exposure by the people who are working here. Maximize the distance from the source and shielding to avoid scatter. Avoid severely angulated views. What about physiologic monitoring of the patient? It has to be continuous. Cardiac rhythm also continuous, mostly the 3 Einthoven leads. Systemic blood pressure at intervals until you can get an invasive measurement which will be continuous. And you have to have the capability to measure arterial blood gases and ACT times. What about accreditation? This you can see it pausing the video. Now let's move on to pre-procedural preparation of the patient. The benefits have to be very clear and they have to outweigh the risks. You have to know any prior allergic reactions of the patient. Lab tests have to be at least 2 to 4 weeks old or more recent if there's changes in this patient. Medications. Basically a patient that is anticoagulated. If you have warfarin, discontinue it 3 days before taken for a diagnostic cath procedure, cath lab diagnostic. The INR has to be 1.8 or less for femoral procedures and 2.2 or less for radial procedures. Dabigatran inhibits thrombin. The glomerular filtration rate, if you have it more than 80 ml per minute, discontinue 24 hours prior. And the lower the filtration rate, the more hours you have to suspend this medication. If the PCI is performed, if it is not only diagnostic, you have to multiply the times by 2. If you have direct 10A inhibitors, you have to also base on GFR. You have 2 options. If the GFR is 30 ml or higher, discontinue 24 hours prior. If less than 30 ml per minute, discontinue 36 hours prior. Preparation of the patient. Aspirin and other oral antiplatelets, don't stop them. If you have metformin, don't give the morning dose and give it till 48 hours after kidney function stabilization. All patients should be measured with the risk for contrast-induced nephropathy. Anaphylactoid reaction to contrast, it's less common with arterial administration, and pre-medication includes prednisone or hydrocortisone, cimetidine, and non-selective histamine antagonist, and diphenhydramine. Fasting should be 2 hours for liquids and 6 hours for solids. And pre-procedural hospitalization for patients that are severe CHF, stage 4 kidney disease, oral anticoagulation that needs bridging. Intraprocedural care, you have to, let's see, if you want to do hemodynamic measurements, do this before using contrast or vasodilatory drugs, which will change the results. These are the major complications. 0.5 to 0.08% will have complications. This is pretty good news, and it's pretty low number. Take into account all these different complications. You can pause the video, but in general the complication rate is pretty low, and the major complication is bleeding. We will see it next. There is no absolute contraindications. That's why it's highlighted in yellow. They are relative contraindications. That's why if the patient has acute kidney failure, that doesn't mean the patient cannot be taken to the cath lab. For example, here you have a non-axis site bleeding, usually unmasks comorbidities, and it's worse prognostically. If you have axis site bleedings, you can have an hematoma, you could have a pseudoaneurysm, you could have a fistula, arteriovenous fistula. So here are the different managements you should do for each patient. Pause the video to read it through. These are other complications like transient hypertension, anaphylactoid reactions, neurological complications, stroke, and death. And this is the last for this slide. I'll pause the video right now.